See a few friends here. Joyce, hello, how are you?
Oh, Jyoti, yes, I'm fine, thank you. Good to see you.
And you. I haven't actually seen you. Good to hear you.
Oh, that's true. Sorry.
Hi, Ravi. Good to see you as well. Angela, Tochum, Susan, lovely seeing you all. Thank you all for so much for coming. So can we get started? Would that be all right with everyone now? Temi, have you got the people that we wanted? I can see 18 participants. Yep, okay, fantastic. So thank you all for coming today. And I hope you all come for the right meeting. As you say in the first page, it is a low-calorie diet training for referrers. I think some of you might have attended this training before, so it's a refresher for those people that it is the first time. A really warm welcome. It's going to be an hour that we could go through the referral processes, the criteria, talk about the actual pilot, and obviously at the end finish off with questions. Next slide, please, Temi. Temi, can I can I ask, can I control these slides? Can I tick the button and do it myself?
I'm not sure if you can.
Okay,
it's coming from my side.
Okay, not to worry, that's fine. So just a bit of housekeeping. The meeting is being recorded. It's going to be shared with people or accessed by people that aren't here, also by yourselves as and when needed. It'll be held on the Training Hub website and we'll share all those details with you. It'd be really helpful if you could add your name, role, and a designation in the chat box. Mute your microphone if you're not speaking and use the chat function to share thoughts. I'll try and multitask. I'm usually very good at it, but if I do miss something, then please ask at the end, save that question. But if you could save the questions to the end, it would really help. I will try and sort of pause in between and see if there are any burning things, any themes coming out in the chat function. So please feel free to raise your hand if required. Next slide, please, Temi. Hello, Belinda. Okay, so this is what we're going to try and cover in the next hour. It's quite packed and a lot of information, which is why we really wanted to record it so people can then also listen to it later on. I've already welcomed you, so I'm going to skip that. Introduction via the chat box. So please do your introductions, and we'll in the next sort of slide we'll do our introductions. I'm going to talk a bit about the background of the program. We're going to then hand it over to Komal to talk about the actual program, what happens when a patient's referred, etc. I'll then take over talking about the referral criteria and medication guidelines changes. And Richard will then talk about the operational elements, the referral forms, etc., finishing off with Q&As. So hopefully you all can stay till the end, but please feel free to sort of add in the questions in the chat box if you cannot stay, and just let me know so I can incorporate those answers within the talk. So next slide, please. So here's the introduction. So I'm Jyoti Sood. I know quite a few of you, and it's really lovely to see some familiar names here. I'm the diabetes lead for Redbridge, but also the LCD lead for the ICS. I'm going to hand over to Komal.
Hi, everybody. I'm Komal. I work with Xyla Health and Wellbeing, the providers for the low-calorie diet program. Nice to meet you all.
Thank you, Komal. Next on, Richard, please.
Hi there. Richard, I don't think you can see me, but some of you will know me, one of the program managers over at the CCG. Thank you.
Thank you, Richard. Do we have Faye or Lacey?
Hi, yeah, Lacey's here. Hi.
Okay. Hello, Lacey. Do you want to just do a quick intro?
Yeah, hi, my name is Lacey Fitzgerald. I am a primary care support officer for the CEG. So we host the LCD template and the LCD referral form for you.
Thank you, team. That's really helpful. So any questions, queries, just feel free within the system to let us know. But I also just wanted to quickly mention at this point, within each of the BHR areas, we've got leads. So if there are any queries for Redbridge, come to me. Adil Ansari will be joining us later. He will be the BND lead, and Anne Baldwin, who isn't unfortunately here today, will be your Havering person. And I say this, if there's any questions, queries, medication changes, or anything really to do with LCD, there will be your point of contact. So the next slide, please. Okay, I absolutely love it. It must be Richard's idea to call the originals the originals. So we've got on the right here the original list. So these are the people that joined the LCD. Is it almost a year, Richard, or 9 months or so?
That's right. Yeah.
Yep.
Yeah.
So thank you for supporting and sending all the referrals, but we've now got some new participants. And as you see, it's a really nice spread across BHR, which is exactly what we want and the patients actually need through BHR. So thank you all for participating and attending today. The next slide, please. Okay, I just wanted to talk a bit about the background of why we are here and why this pilot. Some of you may have heard, I certainly had patients in 2017 come to me when they heard that you can actually stop being a diabetic. And of course, lots of calls on this. And when I said to them, actually, you need to have a low calorie diet, I never saw some of them again. But this was actually based, the pilot here is based on two main sort of studies that were done, which is a direct trial, which was a randomized control trial looking at patients with type 2 diabetes. And these were patients in primary care that were diabetic for 6 years. And the outcomes were weight loss and remission of diabetes. And for all these patients, all the medication, diabetes and blood pressure medication was stopped. And as you would see in the third line there, that or just under half of those patients in that group actually had diabetes remission, which is amazing. You know, it's really good results. And these are primary care patients. And as you would imagine, that the weight loss was strongly associated with remission. So the more weight you lost, the more likely that you would remain in remission. And this trial used nurses and dietitians to provide behavioral support. We then had the droplet trial with similar outcomes, but actually in this trial, they used non-healthcare professionals to deliver. So the outcomes were similar. And actually, even if you don't achieve remission, weight loss helps. It helps your general well-being. It helps with the other glycemic indexes and cardiometabolic risk factors. So based on these trials, the pilot is being run, and it's still a pilot. And I'd like you to remember, it's still a pilot. We'll still be evaluating. We'll still be seeing the outcomes, and we'll talk about in the next few slides as to what exactly it is that we're trying to achieve. So just wanted to give you that background. The next slide, please. So the program across NEL, NEL's been selected as one of the 10 sites in England, and we've got about 500 places over 2 years to deliver this. The work in terms of the delivery is being done by Xyla, which is why Komal is here, and she's going to talk a bit more about that. And it is free. Love to hear the word free. So just use that as a selling point to the patients. So the next slide, please, which is, I think, to you, Komal. Sorry, it is still me. This is the aim of the pilot. And, you could imagine any diabetes pilot. We're looking at reduction in weight and maintenance of weight, remission of type 2 diabetes, but also at reducing the glycemic parameters. Medication usage. So as I mentioned before, that patients have to reduce or stop some of the medication. So actually is reduction in medication, but also with this pilot, we're looking at evidence-based around the delivery approaches. So, what is the effective? Is it a group session or is it one-to-one? What actually works? Is building that evidence. And just in terms of remission, I'd just like to mention that the definition we've used for the purposes of the pilot is less than 48, which is the diagnostic criteria for diabetes over 48, or fasting glucose of less than 7, maintained for 6 months without any medication. So that's the criteria that is used for the purposes of the pilot as qualifying for remission, really. The next slide, please. Thanks, Tammy. Thank you. So I'm going to hand over to Komal, but I'm going to have a quick look at the chat function to see if there's any questions or anything at this point, which none that I can see. But please feel free to add them, and I will try and address as we're going along, because there might be some questions that are related to what we're presenting. So with that, I'm going to hand over to Komal to actually talk about the program itself. Thank you, Komal.
Thank you. Next slide, please. So we went over a little bit on the background. Just wanted to bring that back to your attention as far as the direct trial and the droplet trial. Pretty much the same stuff as JOT. So next slide, please. So as far as the pilot program, we did do a pilot this pilot program, and we saw that our results were, we were able to get to 13.5 kgs weight loss at average for the first 12 weeks of the program. I'll go over what that entails. And we saw an average HbA1c reduction of 15 millimoles per mole at 12 weeks as well. So they were pretty promising results. We went ahead and got the pilot program started then. Next slide, please.
I'm doing 2, 3 things together.
Can I please ask people to mute themselves? There's some interference. Thank you.
So as far as the NEL progress so far, we've had 104 patients complete their first 12 weeks of the program. We've seen promising results at 9.29 kg. So this is not as high as our pre-pilot, but keeping in mind that it is fewer patients than there were then, we're hoping to increase this number, also keeping in mind that NEL in general has the lowest starting weight. So it would be the lowest average weight loss as well. We've seen 98.8% patients losing weight. So it's a pretty high number with that as well. Next slide, please. This is a video we've put together, so we can go ahead and play that whenever you're ready. We're not actually able to hear that.
Sorry, what did you say?
We can't hear it.
You can't hear it?
No.
That's good.
Gone again, Tammy. Came and then went.
The sound's gone again, Tammy.
I wonder if you could play it again and just perhaps just see if the sound can come through.
Sorry, did you want me to play it again?
Yes, please.
With the sound.
But Tammy, there seems to be a problem with the sound.
Oh, I can hear it on my side.
That's all right. I think it should be okay. It's music anyway. I think the next one we will have to worry about because those ones are testimonials. But go ahead and play that. Thank you. Next slide, please. All right, so as far as the referral pathway, so you now know a little bit about the low-calorie diet program if you weren't familiar before, but it is, of course, your responsibility to check eligibility. So at the start, you would check eligibility. There are some email searches for that as well. You would then discuss the program with the patient. So have a conversation with the patient, make sure that they are actually interested in joining the program, make sure they have enough information to make that decision. You would then look up the referral form in your system. If you look up LCD, it will pop up. Once the referral form is pulled up, it will go ahead and pull up all the information for that particular patient, except a few things. So you will have to go and manually put in things like date of diagnosis for diabetes and the medication changes. You will also have to give your consent for the referral. Once that information has been filled up, you'll go ahead and send that form over to us. Once we receive that form, we'll obviously check the eligibility, we'll make sure everything looks good on our end, and we'll call the patient to discuss the next steps. The patient then books onto the initial assessment and commits to the rest of the year. It is a year-long program, so they're committing to that. And of course, starting the total diet replacement phase as well. We'll then go ahead and have an initial assessment with them, and we'll continue to contact them throughout the year long, and I'll go into details on that in just a moment as well. We then go ahead and get the patient started. By then, the patient actually has been given all the self-monitoring tools they need. They've been provided with the product as well, so they're ready to get started. Throughout the process, we are keeping in touch with you. So we are going to let you know when the patient starts the program. We are going to let you know when the patient completes the program. And if during the program they do drop out, we let you know of that as well. And if at any point they do have an adverse event, we are letting you know if it needs your attention. Next slide, please. So these are a few of the updates that we send over to you, just milestones that the patient achieves throughout the year-long program. So like I said, once we receive the referral, we let you know. Once they actually start total diet replacement, we let you know, and just other milestones throughout the process, we let you know. So we're keeping in touch with you, and of course, if there are any adverse events or anything that needs your attention, we also let you know. Next slide, please. So as far as the model itself, once the patient gets referred over by you, you have to give them also the medication review. So you will be guided on making changes to the medication in this session. Once you make those changes, you will put that onto that referral form, but you're also going to have to provide that to the patient in writing. So you can either text it to the patient or email it, or provide them with that same referral form just as a copy for them to keep. Once that's been received by them and we give them a call, we make sure they've got all that information with them. We go ahead and get them started. So we order them a starter pack. And this is just a few of the products that they are going to be consuming. They then go ahead and have that initial assessment phone call with us, followed by starting their stage 1. So that's 3 months of total diet replacement, where we speak to them 8 times. So they have 8 sessions with us. It is over Teams, so it is remote. So they do need to have access to a computer, a phone, or a tablet, as long as they're willing to commit to that, the remote sessions. They then move on to stage 2, which is food reintroduction. They're slowly adding healthy foods back into their diet. That goes over for 4 weeks, and we meet with them 3 times in that. They then move on to stage 3, which is their weight maintenance phase. Throughout this is 8 months of teaching them healthier habits, making sure they're doing okay, managing stress, learning about mindfulness, things like that. So they're actually keeping up with that weight loss and staying healthy. We also teach them exercise at this point, so they've got a lot of exercise routines provided to them as well. And we meet with them 9 times during this time, and throughout the year long, they've got 39 online learning modules that they can access through our app. They then move on to the week 52, which is the last week of the program. They have a one-to-one phone call with us, and then we go ahead and discharge them back to you, essentially. Next slide, please. So when we order them the starter pack, they do have options to try all our 6 flavors for the TDR products. So they are going to be consuming these for 12 weeks. So of course, they need to like the products. We have 2 different soup flavors, chicken and vegetable, and we've got 4 different shakes, banana, chocolate, strawberry, and vanilla. They try all the products. They make sure that they like them, and then they go ahead and order them for that 12-week period. So they are consuming 4 of these products per day. So it is like the title of the program entails, it is a very low calorie diet. And we are obviously in touch with them as far as all of their parameters. So we're making sure they're healthy throughout that. We also provide them with a fiber supplement. So they are taking a daily fiber supplement as well. Next slide, please. So as far as the caloric intake, they are at the beginning at 800 calories. They then do increase, and by the end of their food reintroduction, they are at 1500. So they are actually back to their normal caloric intake. They are, of course, encouraged then to keep that weight off and continue with their healthy habits, just so that they continue to keep their weight off. And if they have achieved remission, continue to stay in that remission phase. Next slide, please. So as far as the measurements that we collect during the program, we do provide them with glucometers. So they are taking the blood glucose readings. We also provide them with weighing scales for their weight and blood pressure monitors if they do need to monitor their blood pressure. Next slide. So as far as adverse events, there are a few common ones that we obviously report everything, but a few common ones we see are headaches, dizziness, things like that. As far as being on a low calorie diet, this is expected. If it does reach a point where their symptoms persist, we do have dietitians on our team as well. They do speak with them, and if it does get worse, then of course we keep in touch with you for that as well. Next slide. So these are a few things that we actually let you know of. So we are monitoring them for excessive weight loss. We are monitoring them for their blood glucose being out of range. And as far as their blood pressure as well, same thing, we are monitoring that as well. So if in any case they do have a blood pressure that's not in, or any of these readings rather, that are not in the tolerable range, we do get in touch with them. We do have a conversation with them. If need be, we do add food back just so that they're being safe as well. Next slide. So these are just some of the additional features. The first little booklet over there is the personalized action plan. We do provide that to patients. It's a physical copy so they can write on it and write down all of their goals throughout the program. We do also have lots of recipes and exercise tips on the app, and then just they have the access to the app so they can put in all of their information so that they can self-monitor as well. Next slide. So as far as a patient that is going through the program right now, just wanted to give you guys a heads up, or a personal story rather, on this patient. He is at week 14. He's lost 8.7 kgs. He's got healthy blood glucose levels, which he didn't really expect when starting the program, but he's been really happy with the fact that he's not having to take medication, and he's got excellent support throughout the program. Slide, please. So that's about it from my end, but if you have any questions, feel free to email me. It's komal.tivani@zylahealth.com or also nhs.net. And that's my phone number if you need to contact me. And of course, our website is available if need be as well. Thank you. I'll hand it back to you.
Thanks, Komal. That's been really helpful. I'm just going to pause for 2 seconds and just check if there's any questions, which I can't see any, on the actual referral. So I'm going to ask you to just hold those questions, if you haven't put it on the chat function, which you haven't, till the end then. Great, thank you. Okay, so there is a question about the referral coming through the GPs or from the dietitian. So if you hold that, I will come back to that, and maybe it will be clear as we go through. If not, then we'll address it. So thank you very much for that question. So I'm going to talk now through the referral criteria and some of the medication changes. And in each of the PCNs or practices, the lead clinician may have to make a decision as to who can refer. This could be everyone who's seeing the patients, or they could actually nominate or delegate the responsibility to one person. As Kamal mentioned, there is a search criteria. So, it could be a person within the PCN that has got a delegated responsibility of going through the patient list and inviting the sort of the relevant patients. So have a chat with your teams as to who can refer, but it could be anyone that is through the training and any patient that meets the eligibility criteria. So this is the criteria. You've got to have patients who've got type 2 diabetes. So there's no type 1 diabetics. They've got to be have diabetes diagnosis within the last 6 years. The age range is 18 to 65. The next bit is BMI. So BMI is 27. However, you can adjust it to 25 in patients with the BAME ethnic origin. So 25 for those, but otherwise 27. The next bit is about the HbA1c sort of the criteria. So the way I remember is between 43 to 87. So you can't refer anybody that's over 87. But in terms of the other levels, if you are on diabetes medication, it's 43. If you're not, it's 48. And also the patient should have attended the diabetes review in the last 12 months. There is a bit of an issue here because a lot of patients with, with things pausing, etc. However, if they've had the retinal screening, which was ongoing, and the patient is actually somebody that would have attended, then please do refer them. It's basically suggesting the patient is compliant with the diabetes care generally. The exclusions, of course, I've mentioned type 1 patients. If the patient's on insulin or planning to become pregnant or breastfeeding, absolutely do not refer. But also if they've got significant comorbidities, if the patient's really ill, you've got cancer, you had a stroke, and where they require that nutritional supplement, they require the diet, and actually they will not be able to comply with the diet itself, then please don't refer. Severe heart failure, severe renal impairments, and active liver disease, eating disorders, porphyrias, and all these will be actually, quite obvious to you. Patient with proliferative retinopathy that's not been treated is simply because, the fluctuating blood sugars or sudden reduction in blood sugars actually can make retinopathy sometimes worse. Also, patients that have lost weight or are part of a weight management program already, because we wouldn't know whether it's that or the LCD that's caused the weight management, weight loss. Patients that are awaiting bariatric surgery, also please do not refer unless they're actually, quite happy to cancel the bariatric surgery. Or a patient that you feel will not be able to tolerate the demands of the actual program, which Kamal's just talked through. Now, this criteria, what I do is we've got a few people that are referring, so I've actually stuck it on the walls because it's quite easily to forget when you are looking at patients. And initially, certainly some of my referrals, I actually, I think I probably used the wrong age. I think I remember referring somebody who was 66, 67, completely forgetting it was actually 65. It was right in the beginning. So things will happen, which is why I stuck it on the wall so you can actually go through the referral criteria as you're referring. Quite helpfully on the referral form itself, this is the first page, so you should be able to see if the patient fits the criteria, even if you don't have it up on your wall. So this is really the basic bit about referrals. So next slide, please. And all these things will be shared with you, so you don't have to frankly write anything. Now, this is just a bit of probably some tips on how to enhance the referrals. Now, what we did certainly in the practice was make sure that every referral was on the same page. They all absolutely understood the program. So there is a bit about doing some teamwork and making sure all the referrals understand what they're referring, who's referring, and just adding a bit of a housekeeping sorted out within the practices or the PCNs. Obviously, you will also, when you select the patient, you've got to use the positive approach of selling the program. And what I do is I send the video that Kamal's just shown via AccuRx, and I send the leaflet to the patient when I've had the conversation and introduced the idea. I let them then sit and and think about it for 2-3 days. I then ring them back and answer any questions they have about the program. And actually 9 out of 10 times, people are happy then to be referred at that point. If they obviously feel that they don't want to, they need more time, I actually pass them to my social prescriber who's got some motivational intervening skills that can then help motivate the patient. So you utilize the other sort of roles within the practice. Obviously, telling them it's free, telling them that there will be support through the whole year is really helpful. Some patients, and this is actually true, most of the patients will say, well, actually, I feel hungry. But most of the participants have reported that's not a major issue. And in fact, if you lose weight, you feel much better, as we all know. And also, when you refer, and I've made this mistake myself a few times in the beginning, I would say, is actually not handing the medication adjustment sheet. And you know what I mean when we move on to the next few slides, is actually giving to the patient what medications are going to be stopped, what they're going to continue. And that's really, really crucial and key. And I'm going to be slightly embarrassed sharing the story with you. Right in the beginning, when I referred a patient, they actually stopped. As soon as I did the referral, she stopped her metformin. Luckily, it was only metformin, so no harm done there. But to me, then it reiterated. So now I actually say to them, please read out the medication adjustment and tell me what would you do? Because that patient, as soon as I did the referral, stopped her medication rather than actually, and and maybe it was my communication, but obviously I thought I said day one, but she'd stopped it. So just want to share that little story and the importance of now telling them to read back the medication adjustments is I think quite crucial. Next slide, please. And again, each patient is different. You might not have to be someone, but that to me really helps. I think I've talked about this already, but the responsibility here are that you provide the right information. And as I said, there is a link that I will ask Temi to share later on the LCD diet program. It's sitting on my AccuRx, as is the video. So I actually share the two links, allow them to sit over it, think about it, and then confirm. I fill the form with them there, and then I share the medication adjustments via AccuRx again, because it's sitting via AccuRx. I get them to read that over to me, and the referral is done and dusted. But your responsibility also is to make sure that you are there if they report any adverse events, i.e. the sugars are going suddenly very high, low, or the blood pressure changes, etc. So you're there as a point of contact to respond to the changes that would be required in terms of the medication when they go through the program. But also the expectation is that you will arrange a review at 6 months and 12 months of starting the program. So as soon as we get an alert that the patient is enrolled on the program, we at the practice set up an AccuRx. You can set up a forward dated invite on AccuRx at 6 months and 12 months. The patient will get it. So I don't have to remember. They will then get a reminder at 6 months to contact for blood tests essentially. And based on the blood test, any medication changes. So I'm just going to quickly glance at the chat. There's nothing there. So I'm going to move on to the next slide. So I hope I've made it clear in terms of what the responsibilities are. The next bit is about adjusting medication. And to some people, the next slide, please, Semi, to some people that actually that do medication changes, stopping everything might not sit comfortably with them. But actually, the trials did show that after stopping the medication, within a week, there was a marked reduction in glucose and blood sugar. So actually, it is okay. And we'll talk to you about how to do that. But if it feels a bit odd, it's fine. Just try it on patients who are just on metformin or something, and then it just feels easier, get used to it. But also remember, these patients are not having that sort of spike because they're not eating their usual food. So the blood glucose spike is not happening. So they really don't need the medication. The next slide, please, Temi. I've still got some interference. If people can just go on the mute, that would be really helpful. I can hear some clicking at the background. Angelina, would you mind going on mute, please? Angelina. Right, Temi, are you able to put Angelina on mute, please? Angelina, where's Angelina from? Okay, she's going to carry on, so I'm going to carry on. So This is what
All
the
done.
trial studies. Thank you, Tammy. That's really helpful. Thank you. So this is what the trial showed. As you would see on the left, the glucose within a week, the levels came down to quite a sensible, quite a low level. As was the blood pressure, it's come down nicely. Okay, so actually don't worry about changing if it needs to be changed. The next slide, please. Okay. So I just wanted to also just mention about the safety element from the direct trial. And as you would note, as I said, it was a control group and the intervention group. In the control group, there were more CVD events at 2 years than in the intervention group. So actually, from the point of view of blood sugar and blood pressure control, the approach works. So don't worry about the events. Don't worry that you would cause them any harm, cardiovascular harm. The trial data is there, but actually it's quite safe to do it. Done in a controlled manner, which we'll talk about in the next few slides. The next slide, please, Tammy. Thank you. Right, so this is the crux, and again, it might take a while for people that are not used to stopping prescribing diabetes or blood pressure medication, but this is a really straightforward way of knowing what to do and the actions to take. And quite simply, you start on the left-hand side, the patient on 1 or 2 blood glucose lowering agent, just stop them, okay? If they're on 3 or more agent, you basically stop everything except metformin. And do remember, if the patient is not on metformin, you will stop the drug which is safe. So safe in terms of hypoglycemia, which are DDP4 inhibitors and pioglitazone. And so is GLP. However, GLP is quite costly, and weight loss, we wouldn't know whether it's the weight loss from GLP or from the TDR products. So actually, if they are on 3 or more product and you stop everything but metformin, if they are not on metformin because they couldn't tolerate it and they're on 3 different drugs, it is safe to continue either DDP4 or pioglitazone, okay? But this is what we would want you to provide the patient in writing. And actually the medication change, the sheet is quite clear. It tells you stop, start. So when you start filling it out, you would know it's really straightforward for the patient to read and for you to actually enter as well. So again, reiterating, if the patients are 1 or 2 drugs, stop them on the first day of starting the TDR. If they're on more than 3 agents, stop everything but metformin. If they are not on metformin and 3 other agents, then you could either carry on with a DDP4 or a glitazone. But all the other drugs must be stopped. The next slide, please. So that is straightforward. So these is just a background of the drugs that can be safe. And as you would note, the drugs that are high risk of either hypo or ketosis, these are SUs, the postprandial regulators, which are the glinides, or the SGLTs. So do not give these. These do not go with TDR products at all. So these are completely banned. The red ones are completely banned. The safe ones are metformin, the glitazones, the DDP4 inhibitors. GLP is also safe, but as I said, GLP is quite expensive and actually it can confuse the weight loss. And as pilot, you wouldn't really know what's caused the weight loss. So actually, it's not a drug of choice, but if you have to give it, you can in certain circumstances give it, but you need to just make sure you alert anytime you make changes, you alert the patient in writing and also Xyla, so they should know, and because they're recording and monitoring the patient as part of the pilot. So I hope that's clear. The ones in red are the ones that are banned completely. The ones in greens, absolutely safe. The yellow is also safe, but actually we would recommend don't use that with this product. The next slide, please. Okay, so this is a really good chart just to explain to you in real terms what happens in terms of blood glucose. If this is patient 1, as you see the first box, you would see the patients on metformin, SU, and DDP4. So they are on 3 drugs. You would stop the red ones, which is SU and DDP4, okay? This is patient 2, who's on SU, SGLT, and GLP. Actually, none of them go through, so you would actually just stop everything. You can completely stop all the medication. Patient 3 is on SU, SGLT, and DDP4. You can carry on with the DDP4. Again, this is about the which drugs are safe. So patient 4 is on DDP4 or PIO, SGLT and GLP. So you could either carry on DDP4 or on PIO. Okay, so I hope that's made sense. And just to reiterate, you can, pay if 1 or 2 drugs, you can absolutely stop. If there are more than 3 drugs, you give the one that is safe, which is metformin and DDP4 and glitazones, which are safe. Yeah, let me just check if there's any. And this might just appear quite confusing to people that are not used to prescribing drugs, etc. As I said in the beginning, you've got an LCD lead in each of the areas. If you're not sure, please do contact them and they'd be more than happy to help until you get used to these agents. But these actually slides and the pack that comes with the referral forms actually is really clear cut. It will tell you exactly what I've told you now, so you can follow it through. You don't have to remember it all. The next slide, please. Okay, so this is just something that would happen once you've started the program. And as Kamal said, week on week, there will be monitoring patients for blood sugar and blood glucose. And you would do a HbA1c at 6 months and 12 months. So the practice responsibility is to make sure there's a call, recall, and there is a lead person or whatever works for your system. But somebody has to have that responsibility of making sure that at 6 months and 12 months, the patients have HbA1c, but also if the patient does contact in the middle because they're having some problems with their blood sugars or blood pressure, then there is a lead person within the practice that, like a go-to person that will be able to resolve the issues quite quickly. And also the provider, Xyla, will actually send alerts out if they find the parameters are out, the blood sugar, the blood pressure parameters are out of range. They will contact the surgery, and we'll talk about it in the next slide. The next slide, please. And as Kamal's mentioned, the blood sugar machine, the blood pressure, and the weight machines are provided by Xyla. So the patient should have all the equipment, so they wouldn't really need anything from you. So this is just about the threshold where Xyla will make contact with you. So if the blood sugar of the patient remains under 15, actually they will just carry on. If it's between 15 and 19 over 2 sessions, they will contact you. And it is a contact to discuss whether you need to restart some of the diabetes medication. And when you do restart, you still have to follow the same principle. You will restart the safe medication, which is not SUs, absolutely not. Not SGLT, absolutely not. Yeah. And also GLPs, if you can try and avoid, and postprandial regulators do not give, because again, there's a risk of hypos with those. If it's 20 or over, they will contact you in the same day. I'm hoping it would be just a case of starting the patient, restarting on metformin or one of the safer drugs in this case. And you may not have to do anything more, but certainly a dialogue with a patient on the same day and get them started with the medication the same day would be helpful. You would need to explore whether the patient is compliant, which hopefully Xyla would have done, but it'd be worth just checking with that. They are taking the medication. They weren't really unwell. We know blood sugars can go high if you're unwell. So just make sure that they aren't unwell with any UTIs, cough, etc. But there could be some really insulin-resistant cases that the resistant with weight loss will take a while to work. So these patients might need some initial support with some medication until the weight loss reaches to a level where actually insulin sensitivity increases and the medication, etc., or their own insulin starts to work a bit better. The next slide, please. I'm just going to have a quick thing on the chat function, see if there's any questions. None through yet. Okay. So again, this is what I mentioned before, that when they contact you, it's a case of you, or either Xyla contacts you on the same day, or they contact you for whenever you can bring the patient, or you have a review at 6 months and 12 months and the blood sugar is not at target. You can restart the medication, but do let the patient know, and do obviously let Xyla know as well if that's happened, which again would be restart metformin, PIO as a second line, or DTP4, and GLP if really, really needed. And GLP, as I said, is safe. However, it will, confound the results. So actually not something that we would recommend we do. And actually, within in the trial things, and I know they're publishing the 2-year data now as well with the trials, that they haven't really had to use the GLPs as much. So the next slide, please. Okay. So again, reiterating the point, not to use certain drugs, which are the SUs, the glanides. So the repaglinide is the common one used for postprandial regulators, or SGLT during TDR phase. Absolutely no. And if they actually, you feel there is a need to use these drugs, they must actually stop TDR, and they must actually come out of the program. Obviously, if they do start insulin, they've got to come out of the program as well. But you've got to, you've got to put the patient's needs in front. And if they need to start any of these agents, you let Xyla know, tell the patient to stop the TDR immediately, and the patient will need to just leave the program. Okay. So the next slide, please, Temi. Thank you. So that was all about blood sugar. As we said, one of the outcomes we are looking at. Yeah, I will come on that one, Richard. So newly diagnosed, you can, provided your parameters, referral parameters are met. But I'll come to that, Richard, in a minute. So, so I talked about the referral criteria. I've talked about the medication changes needed for blood sugar. This is about blood pressure now. Okay. So you've got to just remember some principles, that there are some blood sort of pressure agents that are used for other sort of indications, which are like ACE inhibitors, the beta blockers, the alpha blockers, the furosemide. So these are agents that are not purely used for blood pressure. And that will make sense when we go to the next slide. Next slide, please, Temi. So what the criteria here is that if the blood pressure is uncontrolled, and if they are on blood pressure medication, just don't change anything. However, if the blood pressure is controlled, adjust one medication on the first day of TDR. And you could do this by self-reporting blood pressure. They could come into your surgery pods, or however you want to do it, but make sure that you adjust one medication on day one. Yeah. Now, it's important you counsel the patient for when they start TDR, because I've showed you that the blood pressure does drop. So the patients may experience symptoms of postural hypertension. So if you have left them on one blood pressure medication on day one, then it may be that they've reacted really well to the TDR and they actually have quite low blood pressure. So just warn them about the symptoms of postural hypertension and actually when to seek advice. Of the patients I've referred, actually so far, I've not had anyone had any problems with postural hypertension or even actually hypotension. They've all been actually okay. So again, reiterating, if the blood pressure is uncontrolled, don't make any changes. But if the blood pressure is controlled, and we've given you the values here, then you adjust one blood pressure medication on day one. Okay, so the next slide, please, Temi. Okay, now when you decide which medication to leave them on, you've got to make a decision about whether this is purely for blood pressure or it's for other reason. Okay, and then you just basically follow the NICE guidelines, and the agent that would have been added the last is the one you stop. Okay, so the NICE guidance is AAC. It was ABCD, but it's all changed upside down, and every 2-3 years it changes upside down. So you basically stop the agent that have been added last, and it'll make sense on the next few slides. To reiterate again, you need to just make sure that you check that the medication is purely for blood pressure, and if it's uncontrolled, you don't make any changes. If it's controlled, you will leave you will stop one medication. Next slide, please, Temi. Okay, so here is the example of what we were saying. So as somebody, when you start the NICE guidelines for, and apply into a patient, you would start with ACE inhibitor or ARB or a calcium channel blocker. So that's what you would do. That the one you will stop first will be the last one. So which would be the alpha blockers, spironolactone, beta blockers. The second one will be thiazide, and third one calcium, but it could be ACE as well, depending on which patient you used it on. And the last one to stop will be ACE inhibitor. Okay, so you stop them first, stop the medication that would have been added last. Okay, the next slide, please. And there are some examples here. Okay, when you are sometimes it can get complicated because a patient will be on certain drugs like beta blockers for heart problems, ischemic heart disease, or alpha blockers for for BPH, etc. So you need to take that clinical decision whether to stop it or reduce it, because there's a risk of blood pressure dropping too much. And again, it'll make sense when we talk about the real example there. So base it on the patient's previous history, your knowledge of the patient, with either stopping or reducing some of the medication. Yeah, particularly medication that are not used solely for blood pressure. So again, next slide, please, Temi. It will make sense, I promise, on the next slide. So the provider, this is again, we talked about when the provider will contact you in terms of the blood sugars dropping or going up too high. This is exactly that, but in for blood pressure. So if the blood pressure is really low, like 90/60, the provider, which is Xyla, will contact the patient's surgery the same day to make adjustments to the blood sugar or blood pressure medication. And remember, the one that's added last as per NICE needs to be stopped first. If the blood pressure is in 90/60, 150/99 range, just carry on. Now, this is on the other side, which is the higher range, which is 160/100 to 180/120, or just under over 2, they contact the provider again. If the pressure is over 180/120, again, they contact the provider. And this is about you making a judgment about increasing the medication or adding on or taking the medication. Next slide, please, Tani. Now, this is where it all comes in when I'm talking about blood pressure. Okay. So if you look at the agent, now if you see on the left-hand side, it talks about different drugs. So this patient is on Ramipril for blood pressure alone. Okay. So what would you do? In the first column, it tells you stop Ramipril on day 1. So the patient's only on one medication. You stop it. The patient is on amlodipine, so that's the next line, amlodipine for blood pressure only. You can stop amlodipine on first day, yeah, because it would have been added the last, okay? Now, the next slide or the next line tells you that the patient's on Ramipril because of previous MI. Sorry, Angelina, I think you're if you could just mute yourself again, yeah? So now, if you look at the last column, this patient's on amlodipine, which is for blood pressure. They are on Ramipril. Oh God, the slide suddenly changed. Sorry, just the previous slide, please. Yep. They're on Ramipril because of previous MI. They're on indapamide because of blood pressure, and bisoprolol for previous MI. So what would you do? So again, you could stop indapamide, or you could adjust the dose of amlodipine. So you could reduce amlodipine, and again, according to NICE, bisoprolol would have been added last. However, bisoprolol here is for MI. So you might think actually it's probably not the best agent to stop. So you're focusing on blood pressure tablets only. So the blood pressure tablets only are indapamide. And in this case, it's amlodipine. So the two things you could do is you could stop the indapamide because it was added last, or you could reduce the dose of amlodipine. Okay. So I hope that's made sense in terms of adjustments of the medication for blood pressure. And if you just focus on this slide and you focus that you're only looking at blood pressure medication, but you may have to then also change some of the other medication because actually the patient might get a hypo. It's a clinical decision you will have to make. But the principle being that just follow the NICE guideline, stop the medication that would have been added last according to the guidance for hypertension. Okay, as in the second column, you've got a patient that's on Ramipril and amlodipine, and if this patient's last medication was amlodipine added, you stop the amlodipine and carry on with the Ramipril. But if it was the reverse, that means it was the Ramipril that was added last, and you stop the Ramipril last. Okay, so I hope that made sense, and I'm not confused you there. So the next slide, please. Okay, so some more examples actually, and if you look at that, again, I've got some interference.
Angelina, could you please mute yourself?
Okay,
I'm sorry.
right.
Sorry, I will.
So, oh, Demi, just feel free to just, yeah, feel free to mute people because it just creates, okay. So this is a patient who is on, okay, so sorry, Tammy, just the previous slide, please. So this is, again, some examples here. So this patient is on Ramipril 10 milligram for nephropathy. If you just focus on the first column. What you would do in this case, you could reduce Ramipril to 5 milligram rather than stopping it because they're in for nephropathy and the patient's blood pressure is actually controlled. Yeah. In the second column, you've got a patient who's on propranolol for migraine and doxazosin for BPH. So now this is the type of case that you would have a discussion with the patient. And this is the type of case that you might want to keep a close eye on for the patient, because where technically you could say that, you know, you could try and reduce your propranolol, their migraines may get worse. Or you could say you could reduce the doxazosin, but their BPH symptoms may get actually worse. So it's a case of just having a discussion with the patient and monitoring for symptoms to say, well, actually, why don't you reduce your propranolol? And because there's a risk of hypotension with that. And if your migraines get worse, then let's think of, you know, another migraine prophylactic medication. Yeah. So similarly, you'll have a chat about doxazosin to say, well, can we reduce it to 1 milligram, see how your symptoms are, and let's monitor. So it's a case of having that discussion. Yeah. In the last column, again, quite a careful approach here you need to take. The patients on Ramipril, furosemide, and bisoprolol for heart failure. And all three drugs potentially can cause hypertension. And again, real difficult one, because, you know, you'd have to have, if the patient has got some residual failure and gets quite breathless, you know, furosemide, you may wish to reduce a bit, but you may not be able to reduce it a lot. Ramipril, which is obviously long-term cardioprotection, you might want to reduce that temporarily until the TDR phase is over and then reintroduce it back. Similarly with bisoprolol as well. And again, this is going to be slightly difficult and it'll be bespoke to each patient. But equally, if there are any queries, do contact your LCD leads in the local areas and by all means have a discussion about what you think you should do. But really, more importantly, it'll be the patient discussion. So again, reiterating the point that you need to, that if the patient's blood pressure is controlled, then you reduce, you know, you maintain the patient on one medication, and the medication you would look at are the medication that is for pure blood pressure, and follow the NICE guidelines on that, and, you know, stop the medication that was added last. Okay. But also bear in mind that severe heart failures are excluded anyway, so you might not have that much difficulty in adjusting furosemide, you know, 60 to, I don't know, 40 or 20 or whatever. Yeah. The next slide, please, Tammy. Okay, so again, this is just basically a summary of what I've just said before. If the blood pressure is too low, you would adjust the blood pressure medications based on the level. You might even stop the blood pressure medication based, again, if it's too low. If the blood pressure is too high, you follow the NICE guidance, you know, in relation to adding on the antihypertensive therapy. However, you must ensure the patient is aware, and so is Xyla. Just make sure that that communication, that two-line communication, you keep that going, because again, it's a pilot. They are looking at outcomes, etc. So it'll be really helpful to see what the patient responded to or not. Okay, the next slide, please. Okay, now just bear in mind also when the patient loses weight, there might be other medication that you might need to consider changing the dose of, for example, warfarin, DOACs, etc., which are dose dependent essentially. So just bear that in mind and look at the patient's other medication that might need to be changed because they've had that weight loss. And that's where the communication with Xyla is really important, where they keep you updated on what's happening. And it might well be that you tell the patient that, you know, that we will need to do it more frequently if you're worried about dose adjustment, for example, particularly for the DOACs. then you might need to reduce the amount of DOACs you're giving them. You might need to have a closer conversation and be, just tell the patient you want to review their weight in a month's time, for example. So that is what makes you feel comfortable. Then just do that. Just make it more bespoke to the patient. The next slide, please, Tammy. Thank you. Okay, so I think I have finished my sort of information about the dose adjustments. The only thing I would say is that don't, even if you aren't used to adjusting medication for diabetes or blood pressure, because some of the sort of new roles will be doing this work, don't panic. Maybe initially choose patients that are on not too many drugs. As you know, obviously you've got to be equitable and make sure the patients that fit the criteria is one you're referring, but until you get comfortable, you might want to just choose patients that are on 1 or 2 drugs that you can feel comfortable managing before you extending on to more complex patients. And maybe more complex patients can be done by your experienced GP, and you can then take on patients monitoring that are on drugs that you can, you feel comfortable with. And just remember that, that the trial did show that most of the patients, within a week, they really reduced their blood pressure and blood sugar. So don't be worried. And also there is a real good way communication from Xyla. So the pressure or the blood sugars are going up or down, they will get in touch with you. But equally, doing this for almost a year, I actually haven't had any patient massively significant event from that point of view that I've had to make a call right now, here and now. Most patients have been actually okay. I know it's a lot of information and it'll take time to chew it. I'm going to just answer a couple of questions that were on the chat. One of them was, is it right for newly diagnosed? Well, actually, absolutely, Richard. I think it really is. In fact, that's probably the time they need the behavioral changes, don't they? And if the criteria is within 6 years, and if their referral HbA1c is between 43 and 87, they absolutely fit the criteria. You do have to remember if there are some patients that present quite late, but usually the HbA1c will be much higher because they've lost all the beta cell function and they actually require insulin than actually the TTR at this stage. So most of the GPs should be able to make that judgment. But I think I've referred a few newly diagnosed, and I think actually catching them at that right early stage, changing the behavior, making sure that they're aware of what, how to eat, they lose weight. I think it just will help maintain their diabetes life and support their diabetes life essentially. So that's a good question, Richard. Thank you. And there was another question here about the referral coming from the GPs or from dietitian. I'm not, and we are not prescriptive about that. As long as you feel comfortable, the practice feels that you've got the competency to do a referral. It's down to the practice and the PCN level in terms of where the referral comes from. We are not going to be prescriptive as long as it fits the criteria and people have a good understanding of where to seek help and how to seek help. We're not going to be prescriptive at all. So thank you for those questions, and we'll take some more after Richard goes through the operational bits of it. So thank you, Richard. Over to you.
Hi there. This next section is just to really highlight, and we're joined by Lacey. Lacey, if you want to come on and say anything particular, please do. But when this program started, work has been done by CEG to provide templates for referral and for searches. So have a look for those. And I think, Lacey, it's labeled as total diet replacement. Is that so?
In the referral form?
Yes.
Is it the referral form? Yeah, it is labelled as you just saw it on the, as you can see there, it's the NHS low calorie is what it would be labelled for. If you just type in LCD in the search, then it will bring it up straight away for you.
Great. Thanks for that. It was a bit small on my screen to read, so thanks for that clarification. Is there anything that you want to advise around hints and tips? We know that there had been some early issues in terms of picking up patient data, but I think those have all been resolved at the moment, and the current version is the only version that's up there. Is that it?
Yeah, no, that's correct. Yeah.
Yep. So I don't think there's more that I'd want to say on that. If we could go to the next slide. Temi, do you want to go next slide? And my final slide here is just quickly, is aware of time. Really, from today, please go and act back at your practice. Talk to, communicate to who this would be relevant to, in terms of maybe a kind of process within your practice to help identify patients from the searches, and possibly also within your colleagues, you know, people who this is right for. We were aware when the scheme was launched that practices were contacting us saying that patients were coming forward, and we were having to give them the message that actually it was restricted access at this time. They're not quite said that way. We explained what a pilot was. But this opportunity now is to extend it to others. And if you know people have come forward in past months interested in this service, then there may be members in your team that remember them and they're right to go back to. We picked up on that point about newly diagnosed as well. Consider that in terms of the opportunity. We get regular reports from Xyla, and I will share those with you. It will probably come through Sam, who's supporting me. But what I've really asked, we've got now a total of 30 practices, is roughly, and I know there's a variation in size of practice, which is quite significant, but work on the plan of trying to refer to at least 2 a month. Some of you, Ravi's here with very large practice, you know, you may be able to do way over that. But the point really is that we'd like to see the work shared rather than locked onto just a few practices to deliver. And if we were to achieve, say, 2 referrals from each practice that's been on the training per month, we'd easily hit our target. On that topic, you may have kind of noticed that we have a quota. That quota is for NEL. BHR has committed to 175 quality referrals. By that I mean people starting the scheme, and that's what you get paid for. So when they start the scheme, that's passed back to us, and we can action the payments for you on that information from Xyla. We've got a quota of 175. We're about a third of the way through that. So there's still over 100 slots that we can use out of that 175, but we can do more than that. And I'd quite like in BHR that we do try to do more than that. Not that we're trying to hoover up the quota from the others in NEL, although there may be part of that, but really so that we can maximize our learning from this opportunity. Yes, it's a pilot for NHS England, but we need to learn about how we move people through to remission, and that's something that we're kind of trying to understand from this. So please go back and see, you know, what kind of impact you can do in this regard. There's no penalties around this, but I will be kind of speaking to people if we're running low or we're not seeing that kind of 2 per month coming through, just to understand if there are issues, things that we can help with. And our colleagues at CEG are there for your support as well. So you've heard Lacey's voice, you might have seen her too. But that's really it in terms of next steps from me. Jyoti, any final words, or maybe it's a final Q&A?
Yeah, no, I'm just going to open it to any sort of burning questions, etc. If there's anything here, sorry, this is mine. If there are any questions from anyone here, and I know it's a lot of information we've given you today, but you know, please feel free to contact me. This is going to be recorded, so people that have joined late, you know, we will let you know how to access the webinar today. And as I said, as Richard has shown you the referral form, it's all there. So you just need to read the referral criteria there, and even they talk about the medication changes, etc. So it's really helpful, the referral form actually. And just use AccuRx is absolutely brilliant in terms of sending the leaflets and the links to the video. Really helpful. So I can't see any questions, and I can't unfortunately see any hands, and I don't know where to look for hands here. Adil, oh yeah, so Adil is our BND LCD sort of are your go-to person. And do you want to ask me something, do you?
No,
I
just to
thought you were
mention that actually starting with the new diagnosis, they seem to be the most motivated to
Yes.
diagnose. And it's easier ones to start just because when we are new into it, I think that's when they start with the newer ones and then build up with the difficult ones. And also the forms and the medications are really important. So even if nothing be stopped, just sign nothing be stopped and just sign that up. They do want those forms, and that can delay. So the medication changes forms is really important. Even though there's no medications to be stopped, just still needs to be sent off. Otherwise, it will delay the process very much. And I'm happy to,
Thank you. No, thank you, Adil. Thank you. And I've nominated you to be the person for BND, just so you know. But Adil, that's really good insight, and thank you for that. I can't see any more hands unless anyone else can see hands. No, I can't see.
No, sorry, Jyoti. I just wanted to say also as well that we are working on an LCD pop-up to help when patients are sitting in front of you. So we'll hopefully have that done within the next couple of weeks and then get that out to practices. So that should help as well.
Oh, is this for EMIS?
Yes, this is for EMIS. We're hoping to get a little pop-up when patients are sitting in front of you just saying, oh, kind of check in, see if you wanted to refer them or just chat with them about it. So hopefully that should be up and running within the next couple of weeks.
Oh, that is absolutely amazing. That is amazing. I think that would be so helpful, actually.
Yes, and hopefully, fingers crossed, it will all work properly.
No, brilliant. Thank you for that.
You're
okay,
welcome.
So I can't see any other questions.
there's one question from Ravi.
Okay, hi, Ravi.
Somebody
I can't see hands. I'm sorry.
Can you refer to Desmond and
just
LCD at the same time?
I just wanted to check in terms of the new patients, how do you make a choice, or do you refer both of them? Because COF is asking us to do Desmond referrals. How do you make that choice, or do you have to?
Oh, no, but you can refer, isn't it? Because Desmond is more about what is diabetes, what's the complication of diabetes, and a bit about annual and what's a good diet, what's not. So it's like a half a day program, just giving basic information, whereas this is a bit more sort of obviously a bit more in depth. And so I think you can refer to both. So we're talking about, you know, when I talked about the referral, they're not part of a weight management program. So they're not, you know, on the tier 3 or whichever, there isn't a program they're part of, because then what will happen is they will confuse whether the weight loss is because of this or that program. So, but you can absolutely, because it's you know, it's serving two different purposes. Is that okay, Ravi?
Yes, thank you.
Okay, please help me with the hands if there are any anyone, but I can't see any. Okay, right. So as always, I never finish on time, and I haven't broken my record.
Sorry, there's a hand up.
Okay, sorry, go on. I can't see any hands, so go on.
Angelina.
Hi, Angelina.
Angelina, do you want to?
Yeah, hi. I just want to clarify that if patient eligible for a digital weight management program and for LCD, so I'm going with that what the patient feel comfortable with, yeah? Or
Yes,
can I
you
do
do.
them both?
No, I think you do LCD. If the patient's done LCD, then do LCD, because that will, I think, confuse where because they're going to lose weight with that. Yeah, it's going to confuse that what's caused the weight loss. So I would actually just do. Whereas Desmond is a different one. Desmond is more about educating about.
I'm talking about digital weight management, which we have for now.
I would
not
go
about
for
Desmond.
Yeah, sure. No, what I'm saying is I'm just comparing the Desmond question and this. So LCD is actually sorry, the weight management program is a full-blown program which will support the weight loss, which then will confound the results of this. So if they're going to go for LCD, then just go for LCD if they've agreed.
Okay, thank you.
Thank you, Angelina. There's another hand I can see on the left hand. So I don't know whether whose hand is it, because I can't actually see anything now for some reason.
No, that was the only hand up.
Okay, that's fine. Thank you very much. Okay, guys, so I'm going to leave you now. I hope you I hope you've enjoyed it, and I hope you've learned something, and hope you start referring. But as I said, there's loads of help and support, but do go back to your teams and start looking for the searches. But I'm really looking forward to the pop-up, pop up on the emails. That'd be really so helpful. But thank you and happy referring and have a good evening. She'll see you all soon.
Lovely, thank you.
Thank you.
Bye now.
Thank you.
Bye.
Bye.
Thank you very much.
Thank you all.